Well, thank you so much. We'll get started again this afternoon. My name is Karen Drenkard, and I am the Chief Clinical Officer at Get Well Network, where I lead the O'Neill Center, which is a center to advance the science of patient and family engagement. And I'm also serving as a member of the Planning Committee. And it is my honor and privilege to kick off this session called Implementing a Research Framework, Science and Policy Implications. And we have a fabulous panel to really take us to the next level here. And I'd like to start by introducing my colleague and friend, Susan Hassmiller. And Susan is the Senior Advisor for Nursing at the Robert Wood Johnson Foundation, where she oversees the RWJF initiative, the Future of Nursing Campaign for Action. This is dedicated to implementing the recommendations of the well-known IOM report on the future of nursing, leading change and advancing health. And Susan's going to share remarks and comments today about the future of nursing, credentialing, and efforts to improve quality. Thanks so much, Susan.
Thanks, Karen. So I appreciate everyone getting up here, or some of you getting up here like Jack usually does. And with a disclaimer, I am not a nurse. So I have a disclaimer. I am a nurse, and I am, I would say, somewhat of a policymaker and a program developer and implementer and a funder, but I am not really a researcher. So I have learned a great deal, as I think was the intent of the committee in asking me, let's get her here and let's get her to learn about all of this. So it was a good strategy, and I, I did my homework, and thank you. And I'm very glad, even though I have not really looked a lot at credentialing and credentialing research, I am, after reading the papers and being here today, I have to say I'm very glad that people are doing this work. It is really very important. So what I thought I would do, oh, boy, that does flip quickly. Okay, what I thought I would do is quickly go through the some of the highlights of the IOM report on the future of nursing. And as you probably know, that when that report came out in October of 2010, we did not want it to sit on a shelf, so we immediately started what was called at the time a big implementation project, but is now called a big national campaign. And we have action coalitions in every state working on implementing these recommendations. And the three biggest areas within the report, the areas in which the majority of those recommendations reside, are in the areas of practice, education, and leadership. And there are certainly lots of implications for credentialing research. So the first one, I thought there would be a little screen here. I'm sorry I have to keep turning around, but nothing is showing up here. I don't know if it's supposed to, but that's okay. So that's okay. So with our area, our work around scope of practice, otherwise called removing barriers to practice and care, you know, there's a lot going on. There's a number of states working on this. You can see the dark green areas in particular are those states that have implemented legislation since the report was released in October of 2010. And the, the lighter green areas are states that really had full practice authority before the report came out. The yellow areas, I don't know if it's not so yellow, it's a chartreuse, I guess how it's showing up here. Texas and Kentucky and Utah and New York are states that are moving along much more slowly, incrementally. So, you know, and there has been progress, I have to say, even though there have been just 6 states, there is a lot of pending legislation and people are working on these things, and organizations are coming to the fore, like the Federal Trade Commission, with the understanding that there needs to be more movement. So with all of the success, you are aware that there are still immense barriers in this particular area. In particular, I wouldn't say individual physicians, but some physician organizations have claimed that nurse practitioners are not practicing with the same quality. They don't go to school the same number of years as physicians. Therefore, perhaps, again, not providing the same quality of care as they would be. So a question, would credentialing, what is the relationship between credentialing with nurse practitioners, and what more evidence do we need in this arena, and would it make a difference in moving this agenda further along? And then there is our work around academic progression in nursing, our 80-20 recommendation, the recommendation that would like for more nurses in this country to have a baccalaureate degree, at least 80% by 2020, increasing the number of doctorates, implementing nurse residency programs, and promoting lifelong learning. The IOM committee found that there was a bit more evidence, if you will, to make claims around more nurses needing baccalaureate degrees. Even though the committee made general recommendations around lifelong learning and the need for lifelong learning and the need for more residency programs, the committee didn't feel like they had enough evidence to say what that lifelong learning should look like, that trajectory in particular, and what residency programs should look like. So again, you see that we've had success since the report came out, and we sort of do this at Robert Wood Johnson Foundation in the campaign, claim great success no matter what. So since the report came out, 53% increase in enrollees in RN to BSN programs. And Joanne Spetz, who is one of our research managers, is shaking her head yes, that we can claim that, right, Joanne? Okay, we'll do that. So again, where might credentialing research be helpful in this particular arena? Does holding a certification improve performance? Does a certification of a nurse improve patient outcomes? All questions that you have been grappling with today. And then finally, the last area that I have chosen to talk about today is leadership. We have other areas such as data and interprofessional collaboration, which I will use as an example a bit later. But our work around trying to bring more nurses into leadership positions. We know we have a little bit of evidence from the American Hospital Association telling us that just 6% of hospital board seats are taken up by nurses. And in fact, I just learned in trying to update our own data indicators that has now decreased. Now it is 5%. So this is the one indicator that we're looking at, but that's, that's just hospitals. It doesn't mean that nurses are not taking on leadership positions or board positions in other arenas, public health areas, you name it. National Cancer Institute. So there are other ways that nurses are getting on boards and getting leadership positions, but hospital board positions, unfortunately, have gone down. So here, again, great success. The action coalitions all over the country are really working a lot on this. Gap analysis, they're looking at leadership positions that nurses should have or might have in their state, and working to train and build leadership competencies, the 40 under 40, with the next generation in bringing nurses to these positions. But we grapple with too, and as people come back to us and say, well, really, what difference would it make if a nurse were on a board, if a nurse gave testimony versus another person? What is it about a nurse or a nursing background that really makes the difference? And what, in this regard, in this group, what are the credentials? Are there credentials that a nurse might have that, that would lead to him or her being a better leader on a committee, on a board, for example? So let me come to my last slide, because as I was, thinking about the campaign and all of the work that we're doing and linking it to the credentialing research agenda that you are working hard on, I thought about my own role at Robert Wood Johnson Foundation as a program person, as a policymaker, as a funder. And I thought, what difference does this make? And I really appreciated Patrick. I don't know if he's in the room anymore. A real bona fide researcher. So Patrick, you gave me the permission to say, does this make a difference? And what part of this credentialing research makes a difference? For some, sufficient or even extensive research will never be enough. Will never be enough. And we know that as we try to drive agendas and push policy forward, we know that research is necessary. And don't get me wrong, I would never say, and I would never want to be quoted as one who would say, stop the research. No, we depend on research very much in our work. We couldn't live without it. We fund a lot of research that we in particular need to drive policies forward. But there is a balance, right? There is a balance. We can't let the perfect be the enemy of the good. Sometimes you have to determine in a particular policy, instead of working towards what I've heard a lot about today, instead of working towards patient outcomes, this is going to be best for patient outcomes. Those process indicators sometimes are just as important as the end result. So the example I wanted to bring you in particular, and it's a live example at Robert Wood Johnson Foundation, and it has to do with interprofessional collaboration. So for years, and I've worked in that particular realm for a very long time, interprofessional collaboration. In policy and program development, in some research, and we know that we don't have all the evidence we need to say definitively that interprofessional collaboration makes the ultimate difference in patient outcomes. We don't have that evidence, do we? We don't. But that didn't stop the Robert Wood Johnson Foundation, for the first time in the history of the foundation, to close down 10 of its most significant human capital leadership programs, clinical scholars, executive nurse fellows. What we did have evidence around was those process indicators that I call them process indicators. You had some different words for them, signals, right? But there are process indicators such as when you work together collaboratively, we do know that there is a trust that develops. It has to do with relationships, right? When you trust each other, sometimes things just work out better. When you understand each other's roles, and that's what happens when you practice on an interprofessional level. When you understand each other's roles, when you trust each other, when there is a sense of teamness, it does make a difference. We know that makes a difference. So what Robert Wood Johnson did with that limited and not evidence out here was they closed their 10 programs that were unidisciplinary. That was just nursing and physicians singularly learning on their own. And Robert Wood Johnson has said, we know teamness, trust, role clarity, we know that's going to make a difference. So we've chosen to sunset those programs and build from scratch interprofessional leadership development programs. So that is what I would leave you with. I did a very, very quick thumbnail sketch of, I hope, convincing you that we depend on your work. We depend on the research and the questions that you will come up with. And who knows, we may even look at those questions and see what might be relevant for our own agenda. And then I've given you an example of, but in the end, we have to keep moving. There is a balance. We can't let immovable, we can't be immovable because we don't feel we have enough data. Thank you.
Thanks so much, Sue. And if you have questions, write them down on cards because we will take the questions at the end. And now it's my pleasure to introduce Kathleen Gallo. And Kathleen is the Senior Vice President and Chief Learning Officer for the North Shore LIJ Health System in New York. Within North Shore, Dr. Gallo has served as the System Director for Emergency Medicine and the Vice President for Emergency Medical Services. And her presentation today is called Encouraging Nursing Certification and Assessment in Healthcare Organizations. Thanks so much, Kathleen.
Thank